Thank you very much, Steve, for that review of where we are with clinical trials. While my disclosures are up, I'll just say that all three talks are summarized in manuscripts in the education book. So if you want all the references and the lists of trials I'm going to talk about now, they are all in the educational book. So my role in the last talk here is to look about how we go forward, how we overcome endocrine resistance, given the science that we've discussed, and how we introduce new agents. And I really want to draw some principles out from the studies that have happened recently and guide us in a direction as to the sorts of studies we need to be doing, and perhaps those that we should not be doing. So this is my version of the NCCN guidelines about how to manage advanced hormone receptor positive breast cancer. We use the clinical factors about the site and extent of disease, patient symptoms, the tumour factors related to estrogen receptor and HER2 status, and the treatment-related factors in terms of treatment-free and disease-free interval to make a basic decision with our patient whether we go down the route of endocrine therapy for non-life-threatening hormone-responsive disease or chemotherapy for hormone-unresponsive or life-threatening disease. And as Steve alluded to in the guidelines, up to 3 lines of endocrine therapy are recommended if you have response on each occasion. And on each occasion, if you do not see any initial response with each line, then we know we need to move to systemic chemotherapy to palliate symptoms, but we may come back to endocrine therapy in some form of maintenance option. And in terms of the benchmarks that we're talking about, the median PFS for first-line endocrine therapy in responsive disease can range between 12 and up to 15 months. While in the second-line setting, as Steve has just summarized from a variety of trials, including EFFECT and SOPHIA, the median PFS that you need to beat with endocrine therapy alone is 3 to 4 months. So I think these are benchmarks we need to think about when we're designing combinations with novel agents to improve upon. Now, we know from the current endocrine treatment options that we have tamoxifen and aromatase inhibitors. Fulvestrant may have a role as well, but our limitations are de novo and acquired resistance. And Todd nicely summarized some of the key factors relating to retention and expression of estrogen receptor, some evidence for growth factor crosstalk, increasing evidence for downstream intracellular signaling, and perhaps multiple other pathways that have also been implicated. And the challenge we face, as Eric Weiner said in his nice discussion this morning, is the plethora of drugs that we now have available. Many are orally active and generally well tolerated and can reverse endocrine resistance in vitro. So we're now faced with a multitude of options, and the question is, how do we take it forward? Now, this is my cartoon of a few years ago that I've adapted again here to look at how we use signaling therapy. Our current endocrine therapy will either deprive the ligand or will interact with the estrogen receptor and will affect reduction in ER-positive growth. But we can look at a variety of different signaling mechanisms, whether it be IGFR, type 1 growth factor, or now FGFR, that drive the pathways of either RAF-MAP kinase or PI3 kinase mTOR. And the key factor to notice here is that it's the phosphorylation of estrogen receptor by either mTOR or MAPK that ultimately translates that crosstalk. So the strategies that we've looked at are therapeutics that will either be antibodies or tyrosine kinase inhibitors to block the various transmembrane growth factors. We've looked at now a variety of drugs against mTOR and increasingly now looking at PI3 kinase specific inhibitors to come a little further downstream. And I'll highlight some examples of other drugs such as SRC inhibitors that have also been utilized. So the key questions that we need to consider when thinking of any new agent is, firstly, is the target relevant to hormone receptor positive breast cancer? Is there some scientific rationale and evidence that the therapeutic can reverse or even prevent resistance? And can we identify or select patients based on expression of a validated biomarker? And when we come to think about our clinical trials, we must think carefully about stratification, and I'll use an example a little later on of how this is important, because prior endocrine responsiveness helps us get round the problem of heterogeneity of patient populations. We must choose our endpoint correctly sometimes response rate is not going to be helpful in a phase 2. PFS and OS are ultimately what we need to look at. And we must always consider that whether we're adding something to endocrine therapy, which is well tolerated, we don't want to swap it for added toxicities. Now, I'm just going to spend a little bit of time about growth factor just to highlight some principles that I think we've learned, including the results of the MINT trial. Kent Osborne's group were among the first to show growth factor expression resulting in either crosstalk and show that ER can be involved in genomic as well as non-genomic signaling. And this very nice experiment in the mouse model first told us that you might be able to, and I say might, add a signaling drug with an endocrine therapy up front in terms of tamoxifen and gefitinib and delay resistance by blocking the pathway for resistance from the start. Now, other animal models have perhaps told us that that might not always be the case, and I'm always been struck by Angela Brody's model here with trastuzumab and letrozole in her aromatase transfected xenografts. Look at the yellow line here with letrozole. You eventually develop resistance to letrozole. But look at the green line with trastuzumab and letrozole, and treatment from the outset did not delay resistance. Rather, when you got to this inflection point here of resistance to letrozole and swapped to trastuzumab either alone or with letrozole added, that's when the therapeutic was of benefit. So this might predict that for HER2, treatment up front would not delay resistance, but treatment at the time of progression might. The story was different for EGFR and gefitinib. So targeting up front could delay for EGFR but might not for HER2. What about the clinical trials? Well, Steve mentioned the gefitinib and tamoxifen or anastrozole trials from Kent Osborne and Massimo Cristonofelli, published a couple of years ago. And there was a hint that in endocrine-naive patients, the xenograft model might be true and you could delay resistance. He alluded to the letrozole and lapatinib study and showed again that our data there suggested that in HER2-negative patients, you could not delay resistance by using HER2-targeted therapy up front, very akin to Angela's model. As far as what we do with EGFR and HER2 therapy up front, the question therefore remains, in endocrine-naive patients, would blocking up front prevent resistance in a properly defined prospective study? And what do you do about tumours that have got ER and HER2 in? Well, in terms of trials that are currently recruiting for patients with known ER-positive, HER2-positive study, these are the two post-approval FDA commitment studies that are ongoing to either look at maximal dual blockade with pertuzumab and trastuzumab or maximal blockade with trastuzumab and lapatinib. And these are currently recruiting in ER-positive, HER2-positive disease. But the study in endocrine-naive, HER2-negative patients with a pan-ERB inhibitor was this study, MINT, which on behalf of the investigators I presented at the poster discussion yesterday. Steve has shown this slide, which shows the design of the drug, a one-to-one randomization with 2 doses of AZD8931, which in vitro is a more potent inhibitor than lapatinib or gefitinib. We went for an endocrine-naive population in several countries around the world and recruited over 350 patients relatively quickly, and these were all HER2 negative. The primary endpoint was, could you delay resistance, as was shown in the gefitinib studies in the subset analysis? The answer was that you could not. There was no improvement from the addition of the targeted therapy. You could not beat a PFS of 14 months for anastrozole in first-line therapy by the addition of the therapeutic, and indeed, if anything, the PFS might be slightly worse. So there is no role for the addition of these agents in first-line endocrine-naive patients, and I think this is a definitive negative trial to close that chapter in our research. Why could the PFS be a little worse? You may be blocking key pathways and accelerating the development of other pathways, so that's a concern for using our therapies in hormone-sensitive first-line that I'll return to at the end. Where we're left with HER2 therapy is to see whether or not we can use the combinations in known ER-positive, HER2-positive breast cancer, and I've alluded to the trials that are ongoing. So let's look at some other therapies and draw some other conclusions before trying to give you some overall direction of where the field is going. We mentioned some FGFR targets that are rational based on evidence of resistance. These are two recruiting trials, and this one here was mentioned in the trials in poster session yesterday. And for IGFR inhibitors, there are a number of actively recruiting trials using either small molecules or antibodies. But we do have some results from this trial down here with ganitumumab, which John Robertson published in the Lancet Oncology recently. If I look at the FGFR network here, this is just a pathway to show you the signaling, which very much like EGFR and HER2 goes down through the RAF/MET kinase pathway, and that may be the dominant intracellular signaling for FGFR. Frequency of the amplifications in ER-positive breast cancer may be of the order of 10 to 20%, but there is preclinical evidence that it could be involved in resistance. Here is the ganitumumab study with AMG 479 with either exemestane or fulvestrant versus the endocrine agent alone. These patients had received prior endocrine therapy and had a response to their prior endocrine therapy. But again, you could not beat the endocrine agent. If anything, the addition of the therapeutic was a little bit worse. So this strategy with IGFR antibodies is perhaps going to prove challenging to take forward. What about our favorite PI3K-mTOR pathway? We've focused a lot on blocking mTOR1, but we may need agents to block mTOR2, which is another mechanism of driving the pathway. And what about agents to block PI3 kinase? Well, this is where the field is extremely busy. There are nearly 20 agents in development, and I've done a color coding here to show either PI3K specific, pan-PI3K, dual PI3K mTOR, TOR1/2, or now AKT inhibiting drugs. And a significant number of these are in development for breast cancer. These are some of the early phase 1/2 studies that are being looked at, but perhaps the two key studies are these randomized phase 2 and phase 3 trials, which are looking in patients refractory to aromatase inhibitor therapy at the combination of the particular drugs. Now, I'm just going to focus on this particular trial here, Fergie, which I've been involved with, to pick up the point about stratification. This is a trial looking at two drugs, either a pan-PI3 kinase inhibitor or a dual PI3K mTOR inhibitor versus placebo on the background of fulvestrant using the loading dose and high dose regimen that Steve alluded to in the previous talk. In phase 1 part of the study, patients initially started fulvestrant while we did PI3 kinase mutation testing, and stratification was then based on PIK3CA mutation or PTEN loss as a determinant of whether that would really identify those patients who would benefit. But secondly, and most importantly in my view, was the ability to separate out the different types of endocrine resistance, much as the TAMRAD study has done, where the benefit of the mTOR was all in the patients with acquired endocrine resistance. Now, a few other examples. The SRC inhibitor have been looked at. SRC is a key protein that is involved in transmitting signaling from growth factors, either down the traditional pathways we've talked about, also involved in the extracellular matrix, which is involved in cell adhesion, metastasis, and also it's involved in ER coactivator formation. So it has multiple purposes in this signaling crosstalk. So very rational to look at the combination of a SRC inhibitor with endocrine therapy. There have been a number of studies that have been undertaken. This is the list of the key ones, and these two first ones with dasatinib have reported at San Antonio back in 2011. Unfortunately, both of these randomized phase 2 studies were negative, and neither of them showed any improvement over the average PFS of 3 to 4 months, 4 to 5 months that we talked about at the outset. So this does not look a particularly promising way forward on the basis of the evidence we have to date. What about other targets? There's a lot of interest in either HDAC inhibitors or angiogenesis inhibitors, and this lists some of the studies that are either still ongoing or again have reported. HDAC inhibiting makes some sense from, again, experiments that Angela Brody's group have undertaken in xenografts. These drugs will modulate acetylation of key proteins, including chaperone proteins such as HSP90, which regulates various client proteins such as ER and HER2 in hormone receptor-positive breast cancer. You're used to this model here, so at this point, when you switch to either atinostat or another endocrine therapy, in the animal model, it makes no difference whatsoever. And you can see the upregulation of HER2 and the suppression of ER at the time of resistance. But if you switch to the atinostat and keep endocrine therapy going, and it doesn't matter whether it's letrozole or exemestane, you get a very dramatic response. And this is because you modulate the expression of HER2 and re-express ER, so you engineer endocrine resistance back again. So this is the sort of science I'm talking about that's important to do to give a rationale that your therapeutic may work. So the ENCORE 301 trial is published in this current month's JCO, so you can see the data in full. It was a randomized phase 2 study in a small number of patients, which Denise Yardley presented 18 months ago. And there was a hint of a benefit, not necessarily statistically in PFS, but there was a hint of a survival benefit for the addition of atinostat to endocrine therapy in patients progressing after a non-steroidal aromatase inhibitor. Now, there is a biomarker that's being studied in this, which is to look at hyperacetylation, not in tumour tissue, but in blood mononuclear cells. So it doesn't tell you about the result or the response in the tumour, but it tells you the drug is doing what you want in the patient. And if patients are getting evidence of hyperacetylation, they were doing better than those who did not. So there is a biomarker of a PD endpoint, but not necessarily a tumour PD endpoint. Endocrine resistance from angiogenesis has also a very interesting history preclinically, with some evidence that VEGF expression can account for endocrine resistance. The combination of endocrine therapy and bevacizumab is clinically safe, and we heard at San Antonio the results of the LEA trial that looked at this in the clinical setting. Patients again were treated here in this open-label phase 3 study to letrozole or fulvestrant with the addition of bevacizumab. And while there was a hint that the bevacizumab might improve things, this did not reach statistical significance. And I think it remains unclear what the addition of an angiogenesis inhibitor in ER-positive breast cancer really is. So the final therapeutic that was hinted to at the end of Todd Miller's talk was this ability to block CDK4/6, and in particular this therapeutic palbociclib, or 991 to its friends, which has been looked at in a randomized phase 2 that Rich Finn presented at San Antonio. Again, the science here suggests that the cell cycle is important, not only in addition to evidence of cyclin D amplification, but also its drive by estrogen receptor in regulating the cell cycle. So it makes a logical target in endocrine resistance to see whether we can target this particular pathway. There's evidence of synergy in vitro when this therapeutic has been combined with tamoxifen. Here we've got a diagram that Rich showed you in terms of the target, and we're blocking here the CDK4/6, which is interacting with cyclin D and preventing the hyperphosphorylation of RB, which is allowing progression through the cell cycle. And the data that we saw at San Antonio were really quite striking. This is a randomized phase 2, and the magnitude of benefit kind of initially makes you think about what is going on here. The key aspects of this study were that there were two parts. The first part of 66 patients were those that were ER-positive, HER2 negative, and this was a first-line study. The part 2 randomized patients who were known to have cyclin D amplifications or loss of P16. You can see the magnitude of the benefit on the Kaplan-Meier curves and the median PFS, as well as the improvement in the clinical benefit rate. And this needs to be confirmed in the currently recruiting randomized phase 3 trial. It's unclear whether cyclin D amplification will really prove a reliable predictor of response here, because ER might be driving other components. So to conclude, I just want in the last few slides to show you what my take on all of these pathways is, and a couple of the lessons that I think we've learned in the last year or so. I've done a little table here of the 9 therapeutics that are really being looked at, and there is preclinical evidence for a role in endocrine resistance, with some of these having a significant amount of data from several groups, others having some preliminary evidence of either synergy or evidence of a role in endocrine resistance. In terms of the clinical data that we have so far, as of 2013, we can see here that as far as the type 1 growth factor receptors, we've got a negative phase 2 that I've just shown you about. IGFR, we've got a negative phase 2. FGFR, we haven't got anything yet. We've got strong evidence of a benefit in mTOR inhibitors in second line, but a negative study in first line. And we can see that for SRC inhibitors, the 2 phase 2s are negative. HDAC, we've got a hint of a response here, and we've got a hint in this randomized phase 2 with the CDK inhibitors. But the lesson I want to draw upon is the lesson between the Bolero-2 and Horizon. I put the two slides up side to side. Now, they're different drugs, so you can't compare these studies. Temsirolimus may be a very different drug to everolimus. But this one on the left, Bolero-2, was a second-line study with 84% of patients who had prior endocrine response. This was the true acquired endocrine resistance. Whereas Horizon was a first-line study, 56% of patients having no prior endocrine therapy. And akin to what I said earlier on with the MINT study and with other studies, maybe blocking your pathway up front in endocrine-sensitive tumours will just allow other resistance mechanisms to come through, while as waiting till your endocrine therapy induces resistance in a key pathway, that's when your time when your signaling therapy is going to really work. So coming back to the NCCN guidelines, because this whole education session was about algorithms for treating ER-positive breast cancer, where do we come back to with our two benchmarks of 12 to 15 months for first line and 3 to 4 months for second line? We have not improved upon this in first line to date, and I think this will be a challenge for the studies that are out there at the moment to do a lot better than 15 months for an AI alone. It may be that maximal endocrine therapy with SERD and AI or whatever could take that further forward. I have worries about using signaling therapy there. But here in the second line, we have had a quantum leap. We've gone from 3 to 4 months to 11 months with an appropriately targeted population with a therapeutic that appears to reverse resistance. This should be an important paradigm shift, allowing greater response to endocrine therapy before we have to cross over to chemotherapy. So my final slide is, while the scientific rationale is clearly interesting, there are multiple pathways implicated and there are no therapeutic shortages of drugs to look at, but there is no single pathway that's dominant. Beware of studying the first-line patient population unless you know that you have a biomarker that's helping you, because the combination strategy could not work. It may not. But the acquired resistant population is the unmet need. With endocrine therapy, we can't do better than 3 to 4 months, and therefore we need to look at that population to take the benefit of endocrine therapy further forward. And we'll see tomorrow in the Clinical Science Symposium the first results from the translational data of both Bolero-2 and TAMRAD, and let's wait and see if that gives us any clue of biomarkers to really select who does, but perhaps more importantly, who does not need that intervention. Thank you very much.